I'm Jason Shire, and welcome to Quick Gastro. Disclaimer time, this is a video on the internet, so we shouldn't be using this to diagnose or treat people with medical conditions. Read the fine print, but mostly this is just for education. Living with IBD today is much more manageable than at any time in our past, and one reason is that our medications are much more effective at treating the conditions. We don't have a cure, but we can keep people in remission for years at a time. The first group of biologics that patients are usually exposed to are the anti-tumor necrosis factor agents, or anti-TNF. These are some of the most effective agents that we have, and come with some of the fewest side effects, especially when compared with corticosteroids or immunomodulators. In today's video, we are going to discuss the options, mechanisms of action, indications, dosing, how to check for effectiveness, monitoring, and common side effects. There are several FDA approved anti-TNF available today, and more coming to the market soon. These include Infliximab and its biosimilars, adalimumab and its biosimilars, certolizumab, and golimumab. It should be noted that some anti-TNF, like Intercept, have not been shown to be effective in the treatment of IBD, and we'll go into that in a moment. The FDA approved indications includes treatment of symptoms and maintenance of remission in moderate to severe Crohn's disease that has not responded to conventional therapy, treatment of fistulas in Crohn's disease, treatment of symptoms and maintenance of remission in moderate to severe UC that has not responded to conventional therapy. And lastly, treatment of Crohn's disease patients who lost response to Infliximab. Of course, these medications carry other indications outside the scope of GI. But how are we supposed to keep track of all this? I mean, they're all anti-TNF, so aren't they basically the same? I'm glad you asked. Let's talk about how these things actually work and why the differences matter. Now, being honest, the quickest way to kill a presentation is to put up a pathway of the cell and explain the mechanisms of action. But bear with me, it's the only way to get through this, and I promise you that once we listen to it, it's going to make more sense. Macrophages release TNF. Specifically, the mTNF becomes soluble TNF. And there are two receptors, the TNF receptor 1 for the soluble TNF, and the TNF receptor 2 for the mTNF. The TNF receptor 1 can balance between apoptosis and anti-apoptosis. The TNF receptor 2 only activates the pro-survival pathway. Infliximab is a monoclonal IgG1 anti-TNF that binds the TNF. Adalimumab and golimumab are humanized IgG1 anti-TNF, and they're designed to have fewer side effects, which may in turn result in different efficacy. Now, a different type of anti-TNF is a soluble TNF receptor 1 called Onercept, and this binds other targets like lymphotoxin A, which changes how effective it is for the treatment of IBD, and that's why we don't use it. There's a TNF receptor 2 protein, Intercept, and while it's very commonly used in rheumatology, it's not effective in IBD because it doesn't hit the pathway at the right point. Lastly, certolizumab. It's an anti-TNF Fab portion that has less efficacy than the full monoclonal IgGs. So while all these medications are anti-TNF, they perform differently, they attack different molecules in the pathway, and they have different efficacy for different conditions. And that brings us to monitoring. How do we keep people safe while they're on this medication? The first step is to make sure that before we start the medication, they don't have any chronic infections that can get in the way. This could include hepatitis B, although we usually check hepatitis A at the same time because if we need to vaccinate for both, let's do that now. And tuberculosis. Of note, we can do a blood test or a PPD, and the quantiferon gold is preferred because anergy, or people who don't amount to significant immune response, can interfere with the skin testing. Annually, we want to repeat those same tests, the hepatitis B and the tuberculosis. Although it may not be necessary, we do occasionally find people who've picked up new infections. But also, we want to do annual ALT and AST testing because there have been reports of patients getting minor liver injuries while taking Infliximab. Dosing these medications starts off very straightforward, but only works in about half of patients overall, so we often have to adjust the dose. I don't need you to memorize any of these medications and their dosing because that's a lot to take in one video, but understand the concept behind why we make the decisions that we do. You may be wondering, why are the doses even different between induction and maintenance? And there's a couple reasons. The first is that we know that it takes more medication to induce than to maintain remission, but it's also one of the three mechanisms we use to prevent antibody formation. The first is that we want to start people with a loading dose. The second is we want to avoid breaks in the medication usage so that we don't develop antibodies in the interim. And the third is that we often use an immunomodulator to prevent antibody formation for anti-TNFs. For general outpatient use of Infliximab, we load by using a 5 mg per kilogram dose. Typically, this medication comes in vials in doses of 100 mg, so we tend to round up or down to the nearest 100 mg. This is given at weeks 0, 2, and 6. The maintenance dose is again 5 mg per kilogram, but it's given every 8 weeks. If the patient has lost response, we have different options to adjust the dose. We could escalate up to 10 mg per kilogram, again rounded to the nearest 100, or we could shorten the interval for every 6 weeks or every 4 weeks. The different options could be used based on the patient telling you that the medication just wears off a week or two early, versus you have a specific endpoint that the patient hasn't hit, and when you check the levels, they're just subtherapeutic, so maybe you want to double the dose. Adalimumab is not a weight-based dose. Everybody gets the same thing. It comes in syringes preloaded with 40 mg. The first dose is 4 of them, or 160 mg. The second dose 2 weeks later is 2 syringes, so a total of 80 mg. The maintenance dose is 1 40 mg syringe every 2 weeks. If they lose response, we typically escalate to 1 syringe, or 40 mg, every week. Certolizumab comes in 200 mg syringes, and the loading dose is 2 of those, or 400 mg, at weeks 0, 2, and 4, and the maintenance is 1 syringe of 200 mg every 4 weeks. Now, if they have trouble controlling the disease, we can escalate to 200 mg every 2 weeks. And golimumab is given in 100 mg syringes with a loading dose of 2 of those, or 200 mg at weeks 0 and 2, and a maintenance dose of 100 mg every 4 weeks. If we need to escalate the dose, we can do it by either doubling to 100 mg every 2 weeks or 200 mg every 4 weeks. After the first dose of medication, we have to decide when do we confirm that they're in remission. And this depends on 2 factors. First, how the medication works. The patient may have a clinical response after a couple of days, but that doesn't necessarily mean that they're in remission. And second, how sick is this patient? 8 to 12 weeks after we start the medication, we want to confirm that the patient is in deep remission. And that means that the patient clinically is in remission, endoscopically they are in remission, and the patient is off of corticosteroids. To confirm that they are endoscopically in remission, typically we do this with a colonoscopy. Although if the patient has mild disease, I'll often be convinced to use a fecal calprotectin instead. And if the disease is in the small bowel, in a location that I can't access with a colonoscopy, then imaging test is appropriate. If the patient is particularly sick at the time of starting the biologic, let's say male 3 ulcerative colitis, I'll typically have them follow up every 4 weeks just to make sure that they're clinically doing well. And for objective confirmation, I prefer a colonoscopy over any other modality. Now obviously, anti-TNF are wonderful medications, but they're not for everybody, and there are some contraindications to usage. The first is that patients can't have active hepatitis B. The second is they shouldn't have active tuberculosis. They should not have a demyelinating condition, and they can't have decompensated congestive heart failure. The side effects are largely infusion-related, so that could be headaches, temperature spikes, or just feelings of malaise for a couple days after the infusion. Injection site reactions are also very common, with itching, redness, and tenderness at the site of the injection. Infections are something that we should be cautious of, but patients don't have to live any differently than anybody else. If they wash their hands and follow basic precautions like everybody else, then their risk really isn't increased over the general population. Palmar-plantar pustular psoriasis is a known side effect where you paradoxically have an increase of TNF in certain tissues, and this tends to be dose-dependent. But the side effect people are most concerned about, physicians and patients alike, is the risk of malignancy, and specifically lymphoma. The interesting thing is that most people I ask who are concerned about young men getting this, and that's because one specific type of lymphoma is called hepatic splenic T-cell lymphoma. But that's a very rare lymphoma. And if I had to think about any group who's at increased risk, I'd think about the elderly, just because they are at the highest risk of lymphoma in the general population. The important thing to remember is that even though there's a significant increased risk on a statistical basis, that risk is only increased by 1 or 2 people per 10,000 patients on that condition. So the absolute risk is still very small. Hopefully this has helped you understand the medications and become more familiar with how to use them, so that you can go back to your patients and start helping them live well with IBD. If you like this video, please feel free to share it with your peers. Be good to each other.